without further ado, in the seventh session of the Ohio State University Nisonger Center's Building Bridges Project ECHO, we'll be hearing from Dr. Michelle E. Rowley-Roberts on trauma-informed therapy. She's the Associate Director for Disability Leadership at West Virginia University. Our learning objectives for today, we'd like participants to be able to recognize the prevalence and impact of trauma in this population, to apply trauma-informed principles in clinical practice, to assess trauma using validated and adapted tools, to adapt therapeutic approaches to address trauma responsively, and to collaborate with support people and address environmental triggers. As I stop my share, I will invite Michelle to the screen. And it looks like we're ready to roll. Dr. Rowley-Roberts, welcome to the stage and thank you for presenting for us today.
Hi, you're welcome. Thanks for being here, everyone. I'm really excited to get to talk to you about something I'm super passionate about, which is trauma-informed care. So we'll maybe dive into this if it lets me. There we go. I want to talk a little bit about the need, and then we'll talk about principles of trauma-informed care, evidence-based assessment, approaches or therapeutic approaches, practical implementation strategies, and ethical considerations. So I think it's important to define our terms. We say trauma all the time, but it's sort of a confusing term because sometimes we mean the events, sometimes we mean the symptoms of traumatic stress, and sometimes we mean the trauma response. So I'm going to get into that in just a second. There are some unique challenges and risk factors for adults with intellectual disabilities when it comes to traumatic event exposure. So adults with intellectual disabilities are at greater risk for stressful and traumatic events compared to adults who do not have an intellectual disability. In particular, there's higher risk for physical abuse and sexual abuse. And then there's a disproportionate incidence rate of post-traumatic stress disorder among adults with intellectual disabilities compared to adults without. So 10% in the general population of folks without intellectual disabilities compared to, 10 to 40% in the population of adults with intellectual disabilities versus 25% in the general population of adults without an intellectual disability. So we see that higher rate. Just to get our terms right, so traumatic events, when I'm talking about traumatic events, I'm talking about exposure to events that are coercive, disrupt a person's sense of self or autonomy, and could cause serious injury or lead to death. So things like neglect, abuse, witnessing intimate partner violence, being the survivor of intimate partner violence, being in a serious accident, oppression, or being left out due to demographic characteristics or cultural factors, natural disasters, and the like. When a traumatic event happens, there's an automatic response that happens, which is the trauma response. It keeps us alive. The point is we're either going to respond by freezing, or fleeing, or fighting. And this is, everybody's a little bit different in what their automatic response is going to be. I'm going to show you in just a second why we continue to behave that way. But yes, whenever a traumatic event happens, it impacts our body and our brain, and our outward behavior is to either freeze, flee, or fight. And this is a sort of an intense slide, but I feel like it's so important to understanding why traumatic stress happens, and so I think it's worth going over. So, when a traumatic event happens, it activates something called the sympathetic nervous system. When the sympathetic nervous system is activated, it releases epinephrine, which is a hormone. Um, epinephrine gives us fuel essentially to react the way that we're going to react, whether we're fleeing or fighting. And when it's released, it activates something called the hypothalamus pituitary adrenal axis, or HPA axis. When that gets activated, a really big word called glucocorticoids are released. Glucocorticoids are a fancy word for sugar. So what happens in the brain is our HPA axis activates and we get a sugar dose. Now you might be like, that might be helpful for fuel, but it actually does something else. It provides your brain with reinforcement for behaving the way that you did. So however you automatically responded, whether you fled, whether you were fighting, or whether you were freezing, your brain's like, great, I'm glad you survived. Here's some sugar. And this makes you more likely to respond that way in the future whenever stressful events happen, even when they're not traumatic events. And this can wreak havoc on a lot of different things. So when that sugar is released, it also activates some of our other systems. So our motor system helps us move. Our cognition and memory, some funky things happen with that. So our brain will remember things that it thinks are important to our survival in the moment, but it will turn off our ability to remember the things that it doesn't think are important for our survival. That's why folks who have traumatic event histories often can't give you a linear story about what happened to them. They'll remember some bits and pieces or some really specific details that may or may not. Your brain thought it was helpful in the moment, and that's why you remember it. And then our reward system are activated. The thing about cognition, so our prefrontal cortex gets shut off. The prefrontal cortex is the thing that helps us with planning and problem solving. Now you might be like, wait, those would be helpful. And unfortunately, they take a while. They take longer than that automatic response of freezing, fleeing, or fighting. So your brain's like, we don't need that. You're just going to do one of those three things, and that's how you're going to live. So following traumatic events, we store memories similarly to how we store memories for positive events, which is in all of our senses. So it can be in sounds, places that you've been, certain touches or sensations in our body. It can be in smells. Certain people might elicit or bring up certain reminders. Our sight, so like what we see, and then our feelings. So sometimes feelings of love and comfort can be trauma reminders for some people. Now I want to talk a little bit about post-traumatic stress symptoms. So there's 4 main symptoms that we're looking for when we're considering a post-traumatic stress disorder. The first is something called intrusion or re-experiencing. So this is having memories come into your mind when you don't want them to. Avoidance symptoms are avoiding people, places, or situations that or feelings about what happened about the traumatic event. Negative alterations in cognitions and mood. This is increased. Oftentimes we see increases in sadness, feeling scared, feeling mad, and having negative thoughts about yourself, others, and the world. feeling like the world is dangerous or scary, feeling like you're unlovable, blaming. Um, yeah, Christine.
One thing to ask is if this is something, there's differences between if it's something that happened in childhood and it's a childhood type of PTSD world, but it's not like an everyday thing every day of the universe. I don't think then they can really count that PTSD as a current one. For instance, like I have a lifetime experience of trauma from when I was uh I was in going through hormones. Seizures were not in control at the time because your hormones are changing. And if you had a granddad that was in the military and it's like his attitude is like saying, "Get out of that kitchen, that's mine." Like that military talk tone. Okay, well, I'll tell you this. I have I have memory of that. It's not like, oh, I can remember that every day of my life. Like I can, like it overdraws me.
Mhm.
It's more called childhood trauma, PTSD, in the nickname title. Um, but if you just have certain things that is from the past that you may remember, but it doesn't take over your life for days every day, I don't think they would be under this PTSD then, because everybody in your life, I don't care, we all have a certain item like that in, no matter if you're DD or you're not.
Yep,
What's your
that's true.
what's your opinion in that? Just to ask.
Yeah, so you brought up a good point. Lots of people experience traumatic events, and only a small subset of folks who have traumatic events have post-traumatic stress disorder.
Yeah.
Somewhere between 25% to up to 40%. And that, just because you've had a traumatic event doesn't mean that you will have post-traumatic stress disorder. Um, but
Plus,
sometimes you do.
plus, the way people with autism, because it's you have to get it narrowed down, they could be repeating themselves because it's autism, um versus a different thing. So it always is based on each person is separate. So, but yeah, I when you have a certain thing, there's also this I think it's called in Inuk PTSD, or this kind that's made for temporary, not permanent. I
Yep,
don't know what.
acute. That's
Acute.
acute traumatic stress disorder. Yep, you got it.
Acute.
Good job. So, yeah, so as Christine was talking about, some folks don't develop symptoms of post-traumatic stress disorder, but folks who do will have these four symptoms. So, intrusion, avoidance, the negative alterations in mood and cognition, and then negative alterations in arousal and reactivity. So, with this symptom, folks may startle more easily. They'll be more alert or on guard, looking out for danger. They might be more fidgety, have trouble concentrating, might react more strongly to situations than would be warranted, and have problems sleeping. Yeah, Alice.
All right. I put it in the chat. I was just wondering, I've heard of the fawn response along with fight, flight, and freeze. Do you have any knowledge about how that can look in adults with ID who have PTSD?
Yeah, so I think about that like here we are. We have like 9,000 terms that mean pretty much the same thing. So that's another way of looking at the freeze response. Um, yeah, so it can look very similar. And the other thing, I didn't spend a lot of time talking about it, but when folks have dissociative experiences, that can be a really extreme freeze response. And so, I certainly want to validate folks who have dissociative experiences as that being a valid response for sure. And I'm just pulling up the chat to make sure I don't miss anything. Yeah, flap response as well. Yeah, that's just like that would be another way of saying like a freeze response kind of in the moment, but we're not really we're not leaving the moment. We're having a big response internally, and sometimes that can come out. Oh, yeah. Good questions, guys. I love it. And then, yeah, good point, Ashley. So someone who has suffered from trauma, sometimes if the situation is very stressful, I'll have a moment that I will freeze and not be able to tell how I'm doing. And it's like a deer in headlights look. That's a great way of putting it. Absolutely. And you're bringing up the point where what I was just talking about, where after the traumatic event, the initial traumatic event is over, sometimes situations, will be really stressful and you'll still have that trauma response. And part of that is because your brain rewarded you in the moment for surviving. And now here's a new stressor, and your brain's like, you should probably do that thing that kept you alive the last time. And it's automatic. We don't have a lot of control over it. So with dissociation, I'm using this term, but I want to define it. It's feel like people will say that they feel unreal, or feel like the world is strange, or they'll experience things outside of themselves. So they're sort of like watching a movie, but it's actually their life. So it's disconnecting from yourself, and that keeps you safe. Like in the context of sexual abuse, where you can't escape in the moment, there's not much you can do. Dissociating is a great survival tactic to help you get out of that situation and help you leave your mind, if you will. So I want to talk about the role of behavior changes among adults with intellectual disability. So I think for better or for worse, there's been such a focus on behavior and less about that internal experiences. And so I have to highlight how behavior can be helpful in understanding post-traumatic stress disorder. So you might see folks who historically no behavioral problems, and now all of a sudden post-traumatic event, you'll see behavioral issues, so irritability, withdrawal, self-injury, skill regression. So they could do something and now they can't, like meeting milestones, like toileting, speech language milestones, and then sleep problems. We'll see as the onset of sleep issues in adults with intellectual disability. So the behavior is important to pay attention to. Usually when I hear somebody say, well, there was a big change in behavior, I automatically want to know, is there a traumatic event that's happened? And I would want to rule that out. PTSD has symptom overlap with so many different psychiatric disorders. It does require careful differential diagnosis. That's my bias, my bent. I want to rule in and rule out, make sure we've got the right diagnosis so that we're providing the right treatment. So Um, traumatic events or traumatic stress disorder in particular can impact all the areas of development. So attachment and relationships, making it hard to, when somebody, especially childhood trauma, when somebody has violated your sense of safety, and often in the context of children, it's usually somebody who you were trusting to keep you safe, like a caregiver, a sibling, another adult. That can make relationships really confusing. Um, so traumatic stress can impact your physical health. So risks for chronic health conditions. Our major chronic health conditions in the US all have links to traumatic stress. And if I had more time, I would go into a lot more detail. I'm happy to answer questions. And it changes our emotional response, so it makes it harder to identify emotions. That's adaptive. If I perceive you as mad, I'm going to be in a much better position to protect myself than if I think that you're sad and now I'm approaching you and you're actually mad. And I've set myself up for getting hurt in that scenario. So it changes our thinking and learning, changes behaviors that I just talked about in the core self-concept. So folks who are in a survival mode often haven't had a lot of time to think about what they want to be or who they are, besides being in a survival mode. When we think about barriers to identification, you've got to bring up diagnostic overshadowing. Unfortunately, that can happen. PTSD symptoms are often overlooked. So sometimes it's an assumption on the part of the provider, thinking that the folks with intellectual disabilities wouldn't experience traumatic events, so they don't screen for them. And if you don't screen for traumatic events, you're not screening for post-traumatic stress. And so you miss it altogether. And then sometimes the symptoms of post-traumatic stress are misattributed to other diagnoses, things like ADHD, anxiety, depression. And then there's some provider training gaps. So oftentimes mental health care providers are not trained well in how to identify and treat post-traumatic stress disorder among adults with intellectual disabilities. And then there's provider and systems level biases that prevent folks from realizing they need to ask about traumatic event histories. And then sometimes it's heavy to talk about traumatic events. And I think sometimes providers can be nervous about doing this, not sure what to ask or how to ask it. And so then they don't, which prevents identification. Yeah, Christine.
One thing that I did in very long time ago, okay? When it was knowing how to deal with stressful things or to get rid of the thought of the stressful item, okay, is using this anxiety kind of frisbee thing, like you're using this frisbee and hitting it as the way to get rid of it. Some people call that, in the joke title, frisbee therapy.
Okay.
Joke title, but but it's the way that whatever you're mad at, you're hitting it on that. Okay? So something to point out.
For sure.
That
for sure.
And it's different. Of course, we have to know that everybody has their own way of learning in different ways. So not everyone learns the same. So if somebody might need to do a physical way, they're not doing it legally to self-harm. They're doing it in the expression way. So you have to look into each case because everyone's case is separate. You can't say that if somebody's trying to act funny doing tango or whatever, okay, that they're really trying to hit or whatever. It's just their brain processing a certain way.
Yeah, it could be.
Thanks,
So
Christine.
I'm gonna,
Yeah,
Give
sorry.
us about 5 minutes to wrap up, and then we'll address any questions that you might have. But I encourage everyone to think about any questions or comments that you'd like to make. Thanks, Christine. Go ahead, Michelle.
so I wanna, I'm gonna brush over this so that I can talk about the treatments. So our core principles of trauma-informed care, being person-centered, developing and establishing safety and trust, offering choices, which helps improve autonomy, collaborating with the client, but also the system, and then empowering our clients to, going the wrong way, to advocate for themselves when they can. And recognizing that traumatic events impact our clients' emotions, their thoughts and development, and their behaviors. Some tangible things that you can do to make your environment more supportive are including predictable routines, helping to identify trauma reminders in the environment, and then making a plan for those reminders. Physical and emotional safety, so something as basic as helping your clients know where the exits are in the building, having a plan for, and this, I think this is particularly important, having a plan for how you're going to protect a client who is identifying their perpetrator of abuse as somebody who's involved in their care team, like a supports person. Certainly have had that happen enough that I think it's important that we pay attention to that and make sure that we proactively have a plan in place for managing. And then, sensory considerations, like reducing the amount of things in our offices can be helpful. As far as assessment, using standardized outcome measures like the trauma information form, the Banger life event schedule for intellectual disabilities, which is a self-report questionnaire, and the life event checklist for DSM-5. I think I sent these to Manisha, but if you need them, I'm happy to send them to you. But these are all free and available for use. For PTSD symptoms, using the impacts of event scale or the International Trauma Questionnaire. Both of these were developed with adults with intellectual disabilities to get at core symptoms of PTSD. Okay. So there's a number of different trauma models that can be used. Something like trauma-focused cognitive behavioral therapy for adults with intellectual disabilities. It was developed for youth 3 to 18 years old, but has been adapted for adults up to 25. So if you work with young adults, this is a decent model. And I'm kind of rushing through because I know we don't have a lot of time, but you should have access to the slides. So happy to go back over anything that I'm glossing.
You're good. You're good, Michelle. Just take your time on especially those main points that you want to make sure that we learn about.
Okay. So cognitive processing therapy. This was is a treatment for adults, and has been developed, or adolescents and adults. Its primary driver is to reduce post-traumatic stress disorder symptoms. And the components of the treatment include teaching about post-traumatic stress disorder, reflecting on how traumatic events have impacted your beliefs about yourself, others in the world, and across 5 themes. So safety, power and control, trust, self-esteem, and intimacy. With prolonged exposure, this is another treatment developed with adults. With prolonged exposure, it's been adapted for adolescents 12 to 18, and reduces symptoms of post-traumatic stress disorder. Components include teaching about post-traumatic stress symptoms, teaching relaxation, targeting traumatic events related to traumatic event related avoidance. So I talked about how avoidance is a big symptom of post-traumatic stress disorder. This treatment directly addresses that through the use of exposure. And exposure is paired with emotion processing. So eye movement desensitization and reprocessing, or EMDR, is another adult treatment. It reduces symptoms of post-traumatic stress disorder. There's been one randomized clinical trial that found a 60% improvement of post-traumatic, or 60% of patients who had mild to moderate intellectual disability no longer met symptom criteria for PTSD. There was increased cooperation, fewer aggressive behaviors, and reduced avoidance, as well as no panic attacks and improved mood and sleep. And the one thing I'll say about EMDR is it is an evidence-based treatment, but there's been dismantling studies that point to not the bilateral stimulation as the driver of treatment change. It is the exposure and reprocessing that is the effective ingredient of the treatment. So as somebody who wants to support evidence-based treatment, I think it's important that our clients know why the treatment is working, so that they can make the best decision about which treatment is best for them. So if you're somebody who's providing treatments, I think it's important to say, yes, this is evidence-based, and it's evidence-based because of the exposure and reprocessing. Not that I've seen. So Patrick asked, does the bilateral stimulation help the reprocessing? No, I mean, it maybe is like a in the moment thing to focus on, but you could do exposure therapy, have like coping strategies as well. So I think that it doesn't necessarily need to be the driver of the treatment. But it is an evidence-based treatment. So if that's what you have access to, then I would say definitely do that. Narrative exposure therapy, or NET, this is a newer evidence-based treatment. It was developed for adults. It reduces post-traumatic stress symptoms. And I put the components of all of the therapies to show you just how similar they are. They all have like a teaching about PTSD symptoms. They all have a exposure component and reprocessing component, which I think is the core thing that is helpful. With narrative exposure therapy, it's all about a written chronological life narrative. I think you could do this in pictures or in art as well, using an art-based model. The narrative should include both emotionally significant negative events and positive events, kind of getting at that balance. and teaching people that they're more than their traumatic events. Mm. All right. That was my rush through. Happy to take questions, or whatever.
Yeah, thank you so much, Michelle. It was great to hear about all of those interventions and strategies to address um, trauma in this population. If you'd like, you can stop your share and encourage um, everyone to ask a question if they have it. And you can use the chat, you can raise your hand or unmute yourself. And we have a question, Anastasia. Hello.
Hi, Michelle. Thank you so much. This presentation was great. I'm wondering if you know of any opportunities for case consultation. So I do CPT and prolonged exposure, but working with the ID population, any consultation opportunities?
Oh, that's a great question. I mean, ideally, that would be amazing. So doing something like an echo, um, certainly, you know, if there were specifics, I feel like, um, I am happy to consult with you if you had specific questions that I could help you funnel. Um, and oh, good. So. I thought somebody in the chat, I was like, oh, is that like a resource? But yeah, I think it is unfortunately one of those things where you almost have to know somebody who knows in order to do the consultation. And this is kind of a niche area where it's hard to find people. But yeah, I'm sorry I don't have a better like I wish there was a great resource, right? Like I'm a big reflective supervision person because I feel like if we're doing trauma-informed care, we need support for our providers because we're often, it, dealing with some heavy stuff. And I think we could do a better job of providing care when we're supported too, which is where the consultation would be so helpful. Yeah.
Yeah, thank you. A reminder in the
Thanks,
chat
Rebecca.
too, that we have one more week if you'd like to develop and present a case and get some feedback from this community. I also see Rebecca in the chat offers consultation and is aware of a colleague that does as well and provided an email address. Kamaya, did I pronounce your name right? You have your hand raised?
Yeah, it's Kamea.
Kamaya,
Normally
thank you.
I put a different name in the chat, but it, never mind. Anyway, I had a question about the situations where the person who caused the trauma is a support person, is on their support team. How could you give any more advice for navigating that situation?
Sure.
Just to
Yes.
clarify, is it the individuals on your case, this individual, it's like a support, is like a family member, DSP caused the trauma? I'm just
Any
okay.
this isn't a specific situation. This is
Okay.
just hypothetical. But if they are, especially if they are a family member or a staff member who is around that person a lot or helps them with their personal care, then how do we navigate that?
Yeah.
I've been in a similar situation. My biological father, he's not in my care anymore. He kind of dipped out when I was 18. At the legal age, the state will, for legal age, he was unfortunately part of my cause. He caused the most of my trauma, not all of it, but most of it. I was also in a very good position where I had other family members step in. That was my situation. I can't speak for everybody. Michelle may have more of a better recommendation or advice, but for me, it was more I've had other people in my life that stepped in when things got bad.
Yeah. So as a provider, I would want to make sure that in my intake, I'm spending some time alone with my client to be able to ask some of these questions that you would get a different answer if you were asking alone versus having the support person in the room. When some clues for me that I'm certainly paying attention to, if I have both people in the room and I'm asking a question and the person, my client, is looking at their support person for answers to every question, making sure that they are, really just watching them to see how they're responding, or their body language might be changing. That's a clue for me, that I definitely want to make sure that I'm spending some time alone with my client to ask some of the trauma history questions in particular. And when clients have disclosed, like, yes, this, there's a trauma history with this person. I want to know more about the role that person plays now, and what if there's like legal barriers. So if, say, for example, the person who caused some of the traumatic events is the legal guardian, that there's more hurdles than you can't just be like, yeah, I can't involve you in care at all. Because they're going to be the person signing consent. In those cases, I would make it very clear from the outset, and I think this is true in general, even if there isn't a perpetrator of traumatic events, anytime you're working with a client and caregivers, I want to make it very clear what I'm going to share and what I'm not going to share with the support people. I don't, sort of a rule of thumb, I don't share what we do in sessions. I leave that up to the client. So at the end of the session, I will ask the client, okay, we covered these things. What do you want to share with your support team? What do you think is important? And I let that, like, the client be the driver of what is shared for this reason. And I sort of set those boundaries at the outset, but especially in the case where there's a perpetrator who's involved in the care, I'm going to be, I would be extra careful and deliberate about what I'm sharing and what I'm not. I also would want to know, do I need to make a mandated report? And is this person in active danger? So there's like a safety piece that has to come into the forefront. I've had situations where I had to call the police to get an escort from my office because I didn't think that the patient was safe to go home with that support person based on what they had been disclosed. So in those cases, you just gotta know what what your options are as far as how to keep your client safe. Hopefully that helps.
That helps.
Thanks, Kamea. Appreciate the questions from the community. Thanks again, Michelle, for that presentation. Really appreciate all of the great information that you shared with us. At this time, we're going to transition into our case study. Again, one more reminder that there is 1 week left. If you have a case that you'd like to develop and present for our last week, we would definitely be open to hearing from you. Today's case will be presented by Alice Bielik. She is a social work intern here at the Nisonger Center. At this time, Alice, you may share your screen and